All right. Well, my name's, in case you missed it, my name's Lauren Moore. I'm the Chief Scientific Officer at the National Ataxia Foundation. And this morning I'm excited to introduce Dr. Anoopum Gupta, who's going to be telling us all about SCA6. So next slide, please, Dr. Gupta. A few housekeeping items before we get started. You can turn on closed captioning using the CC icon from your Zoom menu. Feel free to chat with each other and other attendees throughout the presentation this morning. However, there will be about 15 minutes at the end of the session where Dr. Gupta will be taking questions from the crowd. And if you have a question, please enter it into the Q&A, not the chat function, and I will ask those questions for you at the end of this session. Next slide. So I'm excited to introduce Dr. Anoopum Gupta. He received his undergraduate degree in electrical engineering from Georgia Tech and his medical degree from the University of Pittsburgh School of Medicine and his PhD in robotics from Carnegie Mellon. He completed his residency in neurology at the Mass General Brigham-Harvard Neurology Residency program, and his use of accessible technologies combined with signal processing, computer vision, and machine learning methods to deeply understand how neurodegenerative diseases impact motor and cognitive behavior. Broadly, he is involved in research at the intersection of computational science and medicine. And with that, I will turn it over to Dr. Gupta. Welcome.
Thanks a lot, Lauren, for the introduction, and thanks to everyone for being on the call today. I'm going to give a broad overview of Spinocerebellar Ataxia type 6 today. I'll go over the history for how the gene was discovered, what we know about the mechanism of the disease, and then I'll talk a bit about the management of SCA6. And as Lauren mentioned, at the end, we'll have plenty of time for questions, so please let us know what questions you have. So the discovery of the SCA6 gene was facilitated by recent discoveries of genes involved in Spinocerebellar Ataxias 1, 2, and 3 in Huntington's disease. These were all discovered in the early 1990s, just before the SCA6 gene was discovered. And what was found in these 4 different conditions was that in the gene involved in these diseases, there was what's called a CAG repeat expansion in all 4 genes. And I'll tell you a little bit about what that means. So just as a brief review, within every cell in the body, there is DNA packaged into chromosomes, and we all have 23 chromosomes, and we have 2 pairs of each chromosome for a total of 46 chromosomes. Within each chromosome, you have many genes. You have thousands of genes within a chromosome, and if you unpack a gene, you have these sequences of nucleotides that make up that gene. Every 3 nucleotides codes for 1 amino acid in a protein. So a given gene makes a protein, and the sequence of three nucleotides makes 1 amino acid within that protein. So in the genes involved in SCA1, 2, and 3 in Huntington's disease, there are CAG repeats in the gene. And in a person without ataxia or without disease, there are, for example, in the SCA3 gene, between 12 and 44 repeats of that sequence. That's what's in a typical gene. In the disease, there's an increased number of those repeats. So in SCA3, there's between 60 and 87 of those repeats. And when that gene gets turned into a protein, you have extra glutamine, which is the amino acid that CAG codes for. So the protein has these extra glutamine amino acids in the protein, and that alters the function of that protein. So building upon that discovery that it's a common, in these other diseases, there's a commonality in that CAGs have extra repeats in the gene. Zuchenko and team looked at the whole genome, looked at all the chromosomes, and in a healthy individual looked to see, are there other places in the genome where there are CAG repeats? And they found that across all parts of the genome, there are some 387 locations where there are CAG repeats. And one location in particular corresponded to a gene that codes for a protein that we knew something about. It was a calcium channel that responds to voltage. So when voltage changes in the cell, this channel opens up and allows calcium into the cell. And that gene was found on chromosome 19, and it's called the CACNA1A gene. And so this was a gene of interest that they decided to study further. This location where there were CAG repeats, they wanted to study that gene further. So they looked at genomes from 133 individuals who had ataxia and genomes from 475 individuals without ataxia. And they found that in 8 out of the 133 individuals with ataxia, there were extra CAG repeats in that gene, in that CACNA1A gene. And there were no extra repeats, no individuals without ataxia had those extra repeats. So that was evidence that in some individuals with ataxia, there is an expansion in that gene. And the next step they took was they looked at these 8 individuals with ataxia and with that CAG repeat expansion, and they studied 4 families. And so in four of those individuals, they had other individuals in their family with and without ataxia. And so they tested those family members, and they found that all family members who had ataxia also had those extra repeats. So instead of having somewhere between up to 18 repeats, individuals with ataxia had 20 or more repeats in that CACNA1A gene. And so this provided very strong evidence that extra repeats in the gene was responsible for the phenotype, the ataxia we see in SCA6, and they gave this condition the name Spinocerebellar Ataxia type 6. And this was in 1997 that this paper was published, soon after the discovery of SCA1, 2, and 3 in Huntington's disease. And interestingly, around the exact same time, it was discovered that this same gene, this CACNA1A gene that's now implicated in SCA6, is also involved in 2 other conditions, one called familial hemiplegic migraine, and another one called episodic ataxia type 2. The mutation in the gene is different in these 2 conditions, but it's the same gene. And there'll be a future seminar hosted by NAF that talks about episodic ataxias, where you can learn more about that. All right, so next I'll talk about how SCA6 is inherited in families, and then a little bit more about the mechanism of the disease. So SCA6, similar to other spinocerebellar ataxias, is autosomal dominantly inherited. And what that means is that you need one abnormal copy of the gene to cause the disease. For every gene in the body, we have 2 copies of the gene. We inherit 1 copy from our mother and 1 copy from our biological father. And in autosomal dominant conditions, you just need 1 abnormal copy of a gene from either mom or dad in order to have the disease. In contrast, in autosomal recessive diseases, you need 2 copies of the abnormal gene in order to have the disease. So SCA6 is an autosomal dominant disease requiring 1 mutated gene. And here I'm showing you what it looks like within a family. This is just an example. So in this example family, the father has 1 abnormal copy of the gene shown in blue and 1 normal copy of the gene shown in orange. And the biological mother has 2 normal copies of the gene. Each offspring, each child gets 1 copy from the father and 1 copy from the mother. And so each child has a 50% chance of getting the abnormal gene from the father and then we'll get a normal copy of the gene from the mother. So about on average within families, 50% of the children will have the mutated gene. So if you have a first-degree relative with spinocerebellar ataxia type 6, either a parent has the disease or a sibling has the disease, for example, then you have a 50% chance of having the disease. All right, so now we'll look a little bit more at this CACNA1A gene and what it does inside cells. So I mentioned before this CACNA1A gene that's on chromosome 19 and how it has the CAG expansion in the gene. It has extra copies of the CAG nucleotides, and that results in a protein that has extra glutamine in the protein, and that changes the function of the protein in some way. One of the interesting things about the CACNA1A gene is that it doesn't just produce one protein, it produces two proteins that have different functions. So the first protein that it produces is part of a voltage activated calcium channel that we talked about before. And the voltage activated calcium channel is present in high concentration in large numbers inside Purkinje cells and granule cells in the cerebellum. And it's involved in a variety of processes, but the main thing that it's involved in is communication between neurons. So that's protein 1. And protein 2 is a smaller protein that goes into the nucleus of the cell and turns on and off other genes in the cell. So it's a gene regulator, and it changes how other proteins are activated in the cell. So given that you have these two proteins that are made by this gene in SCA6, and both of those proteins have extra glutamine, there are different ideas for how these proteins result in changes in these cells and resulting changes in resulting in ataxia. So one idea is that protein 1, which is this channel that's involved in communication between neurons, is not functioning correctly. So the communication between neurons is impaired. Another idea is that there's the regulation of calcium within the cell is impaired, which can cause injury and toxicity to the cell. And then with protein 2, some of the ideas are that abnormalities in protein 2 changes how other genes and other proteins in the cell are activated, resulting in injury to the cell. And then another mechanism, possible mechanism, is that with those extra glutamine on the protein 2, it goes into the nucleus and it causes aggregations. It binds to other proteins, and that causes injury to the cell. And that last mechanism that I mentioned is also thought to potentially be a mechanism for disease in other spinocerebellar ataxias that have those extra glutamine in the protein. So if you look at the brain, there are changes that you can see in the brains of individuals with SCA6. In particular, there are several different changes, but the main change you see is a loss of Purkinje cells in the cerebellum. So in this image here, I'm showing you 6 different brains. And in this first individual, you can see this is the front part of the head here. This is the back part of the head. This is a side view of the head, and we're looking at the middle slice. And you can see the cortex here. I think my mouse is disappearing. Here we go. And in the back lower part of the brain is the cerebellum. So this is an individual without ataxia, and this is what the cerebellum looks like in that individual. You can see that there's some black spaces around the cerebellum, and that's filled by cerebral spinal fluid. That's fluid that surrounds the brain. This next image is somebody who has the SCA6 gene mutation, but does not have any symptoms. And you can see that the cerebellum in this individual looks quite similar to the individual without ataxia. Maybe some of the black spaces around the cerebellum are a little bit larger, indicating some loss of tissue in the cerebellum. And as you have individuals with increasing severity of their ataxia, as SCA6 is progressing over time, the amount of space, the black space is increased, again, reflecting loss of tissue in the cerebellum. One of the differences between SCA6 and other spinocerebellar ataxias, for example, 1, 2, and 3, is that you don't see the same brainstem changes. So if you look here in the center of the brain, this is the brainstem. The midbrain is here, the pons is here, and the medulla is here. In these structures in the brain, you don't see changes over time the same way that you see in other conditions. Primarily, the cerebellum is affected in spinocerebellar ataxia type 6. All right, I'm going to talk now about how the diagnosis of SCA6 is made. The diagnosis of SCA6 is made by confirming the diagnosis with molecular genetic testing. You can do this from a blood sample or a saliva sample. Cells are isolated from these samples, and then the DNA is isolated. And you're looking for these extra CAG repeats inside that CACNA1A gene. So should you get tested and when? And there are three main scenarios for considering getting tested for SCA6. The first scenario is you have a first-degree relative with SCA6, but you don't have any symptoms. So as we described before, in this scenario, there's a 50% chance that you will have the SCA6 gene. Now, if you're a minor, we don't recommend testing at this point. And the main reason for that is at the present time, we don't have a medication that can stop or slow the progression of SCA6. In the future, if we do have a medication that can stop or slow the progression of SCA6, that might be a scenario in which testing in minors is recommended. But as of now, the recommendation is to wait for the minor to come into adulthood and be able to weigh the pros and cons on their own with their, using their own autonomy to make the decision about whether to get tested or not. Another time to consider getting tested is when you're planning to have children. There are technologies, in vitro fertilization, using pre-implantation genetics, which allows you to not pass on the mutated gene to offsprings. So that's a technology that can be considered. And that's why this is a time in life to consider getting tested for the gene. And then at other times in life, it's a very personal individual decision whether to get tested or not. And that's a conversation to have with your neurologist, genetic counselor in the clinic. People will sometimes want to get tested as they're making other decisions in the life, job related, etc. Now, the next scenario is if you have ataxia related symptoms and you have a known family history of SCA6. So let's say you have a parent or a sibling that has SCA6 and you're starting to notice changes in your balance, in your speech. In that setting, you would want to see a neurologist and be evaluated. And if during that evaluation, the neurologist takes a history of when your symptoms began, what were the symptoms, how have they changed over time, the neurologist will do a detailed examination to characterize the changes in movement that you're experiencing. And if the history in the examination is perfectly consistent with spinocerebellar ataxia type 6, then it can be inferred without genetic testing that you also have SCA6. Now, there might be times that even with that high consistency between your symptoms and your exam with SCA6, that you might also want to get genetic testing. And that might be if you're participating in a clinical trial or another research study, where it's important to have 100% confirmation that you carry the SCA6 gene, along with the knowledge of how many CAG repeats are present in the gene. The third scenario is if you have ataxia that comes on later in life during adulthood and no family history, you don't have any family history in parents or aunts or uncles or siblings or grandparents of ataxia, it's still possible to have SCA6. It could be a new mutation. It could be that parents passed away from another cause before the symptoms of ataxia emerged. So it's still possible that you have SCA6, and this would be in the evaluation with your neurologist, it would be determined whether it makes sense to do genetic testing for inherited forms of ataxia. All right, so next I'll talk about the clinical characteristics and clinical care of individuals with SCA6. So what's the age of onset? I've mentioned that this is an adult onset condition, and most individuals with SCA6 begin to have symptoms sometime in their 40s or 50s. This is about a decade or two later than in spinocerebellar ataxia type 1, 2, and 3. And I say 40s and 50s, but there's a wider range than that. Some people may have onset in their 20s, and other people can have onset in their late 60s or early 70s. So there's a wide range, but most people have onset in their 40s or 50s. Disease changes slowly over time in SCA6. And at the very beginning of the disease, there's a small percentage of individuals who actually have episodes of ataxia. So they might have a day where they're feeling vertigo or feeling that the world is moving or spinning, or that they're a little bit more off balance one day and then that goes away. So in a small percentage of individuals, there's episodes at the beginning. But then after that, things change very slowly over time. You don't tend to notice changes month to month. Changes are in the time scale of years. Most people with SCA6 first notice changes in their walking and in their balance. Might have an occasional misstep, bumping into things, feeling like the coordination of the walking and the balance isn't quite right. People experience vertigo. So vertigo is a sensation that the world is moving. It might feel like the world is spinning, or might feel like there's subtle world movement that's not actually present, feeling like you're on a boat. There can be changes in speech and in swallowing. In speech, the words might come out a little bit more slowly. They might be slurred as they come out. People will often describe that at the end of the day, when they're more fatigued, that's when it's the most difficult to speak clearly, that they have to focus on their speech and concentrate on their speech in order for the words to come out crisply. So those are some of the changes in speech. Individuals can have changes in the swallowing. So when eating or when drinking, you might cough more often. People with spinocerebellar ataxia type 6 experience vision changes, double vision in particular, and then changes in hand and arm coordination during handwriting, buttons, eating. The coordination of the hands can be affected, and people might feel more clumsy. They might drop things more easily. So when you see a neurologist in the clinic, the first thing that they'll often start with is a detailed history of your symptoms. When exactly did you notice the very first symptom, and what was that? Has that been persistent, or does that symptom come and go? And then how has that symptom changed over time? And over time, what additional symptoms have you experienced? Throughout all neurological conditions, the character of the symptoms and the evolution in time is very informative in the diagnosis of the disease, and also in understanding what symptomatic therapies might be helpful for you. During that appointment with the neurologist, a detailed family history, as we talked about earlier, will be performed to understand who else in the family is affected. Is this condition consistent with an autosomal dominant condition where you in most cases see affected individuals at each generation? Or is it more consistent with an autosomal recessive condition where you don't tend to see the disease at earlier generations, but within your generation, there may be multiple children affected? So family history is important. And then the neurological examination is a critical piece of the evaluation where the neurologist will characterize your eye movements, your speech, changes in facial expression or posture, how your limbs move, how your walking and balances. They'll check your reflexes, the sensation of your limbs. And that combination of assessments of different parts of the motor system is really informative in identifying, is this consistent with SCA6, or are there additional things beyond SCA6 that we might need to consider? It's important it's common, for example, to have SCA6, but then also have neuropathy from another cause, diabetes or alcohol or another cause of neuropathy, and that might be managed separately from SCA6. So we will always want to know in the neurological examination what's consistent with the genetic condition and what might be part of another process that we would treat differently. During that clinical evaluation, we'll review imaging and look to see if, again, is the imaging consistent with this diagnosis, or are there other changes that need to be addressed? So while we don't have medications yet that can slow or halt the progression of ataxia, we do have a lot of medications that can help with symptoms. These are some of the symptoms that I mentioned earlier. For vertigo and world movement, there are several different medications that can be used to suppress the vestibular system and reduce that sensation or that perception that the world is moving. The decision about which medication to try depends both on the symptoms that you have as well as on characteristics on the exam. Do you have nystagmus? Is it horizontal or vertical nystagmus? So each of these medication decisions is dependent on both your symptoms as well as the examination. For individuals who early in the course of the disease have episodes of ataxia, acetazolamide or immunoperidine can be helpful. If you have double vision, prism glasses that are fit by an ophthalmologist can be helpful in reducing the double vision. If you have muscle cramps, there are behavioral changes that can be very effective: stretching, exercise, hydration, also vitamins. If the cramps are worse, there are also prescription medications that can be very helpful in reducing muscle cramps. And lastly, I'll briefly mention a medication called Riluzole. We often prescribe this medication for individuals with different spinocerebellar ataxias with the hope of slowing ataxia to a small degree. But we really need larger scale studies to determine if this drug is truly effective and in whom. One of the most important components to the management of spinocerebellar ataxia type 6 is long-term engagement with physical therapy, speech therapy, and occupational therapy. In physical therapy, the therapist will work with you to support your balance, your gait, overall mobility. They'll tailor the exercises to your level of disability and the things that you'd like to do better at home. Core strengthening is a big part of physical therapy, and that supports balance. Things like yoga and other core strengthening exercises really helps with reducing the risk of falls. And the physical therapist will help fit you to assistive devices. What is the most appropriate given the challenges that you're having? which customization to those devices can support you the most. The speech therapist plays two big roles in the management of ataxia. One is in promoting speech clarity. What behavioral changes can you make, and what exercises can you do so that your speech is more clear and the articulation is better, others can understand you better. They'll also assess your swallow and characterize how you swallow. What sort of strategies can you use to reduce the risk of choking, of silent aspiration, where food or liquid in the mouth can go into the lungs and cause a pneumonia. So speech therapy is a critical part of the management of ataxia. And last is the occupational therapist. The occupational therapists do a lot of different things. In ataxia, two of the things that we rely on the occupational therapist for are exercises to promote hand coordination. As I mentioned before, handwriting can become more difficult. Eating can become more difficult as limb coordination changes. So sometimes weighted utensils and other hand exercises can be very helpful. The occupational therapist will also help assess home safety. Are there specific changes that you can make within the home to improve safety and reduce the risk of injury? For example, through installation of different kinds of grab bars, through making sure that the floors are clear, there are fewer rugs in areas that can be tripping hazards. So these three different services can be very helpful over the entire spectrum of the disease. So that was my last slide. We had a chance to go through the mechanisms of the disease, how to establish the diagnosis, and some of the pearls for clinical management. I'd like to pass it back over to Lauren at this point, and we'd love to hear any questions that you have.
Great. We have quite a few questions already, but anyone who's on the call and has questions, please add them in as we do have about 20 plus minutes left. And thank you, Dr. Gupta, for that presentation.
You're welcome.
Okay, so we'll just dive right in. So one of the questions was, how often is imaging recommended to monitor changes in the cerebellum? And is there a specific frequency, or is it more tied to your symptoms?
Once the diagnosis of spinocerebellar ataxia type 6 is made and you have a genetic diagnosis, a baseline MRI can be helpful, but it's not needed to continue to get MRIs over time, unless, as you mentioned, there's a clinical change and we'd like to evaluate the cause of that clinical change. Following somebody's examination is actually more informative in how the individual is doing than performing serial MRIs. Now, let's say all of a sudden symptoms are a lot worse and we want to evaluate, could there be something on top of the spinocerebellar ataxia? Is there a subdural, a small bleed around the brain caused by a fall or a stroke? Then of course, imaging can be very helpful.
Have you seen rapid decline, like onset of symptoms or increased symptoms after a stressful event such as COVID or other health events?
One of the things across all neurological conditions that can happen is a secondary event, an infection, a head injury, a concussion, can make the symptoms feel worse. Most often after that resolves, with physical therapy and with exercise, you can come back to what we would call your prior baseline, where you were before that event. But we do see across all neurological conditions, including SCA6, that symptoms can get worse after an infection.
Sorry, just scrolling through the questions. So one of the patients says that their wife has SCA6 and has been extremely nauseous almost every day. Has this ever been associated with SCA6?
It would be interesting to know what else goes along with the nausea. Is the nausea associated with vertigo, with that world movement sensation? Is it independent of that? If the nausea is independent of a sense of vertigo, I would look for other potential causes of nausea. And this is one of the things I alluded to before, that a lot of this, or some of the symptoms that you can have in SCA6 may have other causes as well. And so we always want to keep an open mind. Is this symptom attributable to SCA6, or is there another process going on that we can address?
Mm-hmm. Thank you. There was a couple of questions about one type of drug called 4-Immunoperidine, or 4AP. Can you tell us a little bit about that drug and how it has been used in SCA6 in the past?
So 4-Immunoperidine, the brand name for this drug is Impira, and it's approved for use in multiple sclerosis. It's not approved for use in ataxias. What studies have shown is that in individuals who have downbeat nystagmus, so when you're looking straight ahead, or you gaze off slightly to the right or slightly to the left, the eyes have this periodic beating in the vertical direction. And individuals who have that vertical nystagmus, 4-Immunoperidine can reduce that nystagmus. And more importantly than reducing the nystagmus, it can actually improve your balance sometimes. So in individuals who have Spinocerebellar Ataxia type 6 and have downbeat nystagmus, 4-Immunoperidine, which modulates the function of potassium channels, can be helpful.
And I'll note 4AP hasn't specifically been FDA approved for ataxia. Can you talk about what that means and how ataxia patients can still access it?
This is a challenge, but we work through this in a variety of ways. One strategy that we've been able to use is using compounding pharmacies to get 4-Immunoperidine for our patients. Sometimes we go the insurance route and see if through prior authorization we can get it approved. We've had variable success with that, but usually we're able to get the medication for every patient.
Mm-hmm. And just for terminology's sake, that's off-label prescriptions, correct? Where 4AP has been tested in other neurological diseases and is specifically approved for MS currently. So we're using an MS drug to treat ataxia, and we are getting a couple comments from patients saying that they're on the drug and that it did help them in some ways. So a couple questions around the diagnosis. So how important, or how does one determine which type of SCA one has, and is it important to differentiate?
So great question. Each of the different spinocerebellar ataxias is a different gene that's involved in that disease. Let's say you have a family history of changes in balance and speech, but a gene hasn't been identified anywhere in the family. But you see that grandparents, a grandparent had it, one of their offspring had it, their children had it. You start to see that this is an autosomal dominant pattern of inheritance. Then when you see the neurologist, let's say you have symptoms and you see the neurologist and the neurologist evaluates you, the different spinocerebellar ataxias each have their own unique features. For example, in spinocerebellar ataxia type 2, the eye movements can be slow. In spinocerebellar ataxia type 3, you might see some fasciculations or some movements on the face. In spinocerebellar ataxia type 6, it tends to be a more pure cerebellar phenotype, meaning that the movements that are changed in SCA6 are the coordination of the movements. So that helps you identify, which of the spinocerebellar ataxias it might be. That being said, there's overlap. And so oftentimes in this scenario, we'll do an entire panel where there's an ataxia panel, and many of the genes that are involved in different spinocerebellar ataxias will be evaluated. The other component to that question is, is it important to determine the specific spinocerebellar ataxia? And I think it is important. The prognosis of each disease is different on average. Of course, it's very different for each individual, but in general, you can say, depending on the spinocerebellar ataxia, when my symptoms might begin, how they might change over time, what other symptoms should I be looking out for that can be managed with symptomatic medications? Am I eligible for a clinical trial? So these are reasons to get tested.
And yep, it's also very critical to family planning, especially if you're going to be doing something like IVF with pre-implantation genetic diagnosis. You do have to know what type you have in that scenario. So thank you for that. We're getting a lot of really great questions, so hope you're ready to keep going. Here's a couple questions around the diagnosis. So if a person is asymptomatic, but they have decided to go through pre-symptomatic genetic testing, when should they begin seeing a neurologist?
That's a great question. Oftentimes in that scenario, if let's say you get tested and it comes back positive, you'll connect with a clinic close to you. You'll see a neurologist one time. That neurologist can examine you, get your history, see if you might have questions about certain symptoms that you're not sure, is it related to ataxia or not? The neurologist can help discuss that with you and clarify those symptoms. Are they related to something else that we need to address? They'll do an examination to establish, are there some signs on your exam that aren't bothering you, that you don't notice, but are present, that we can track over time? And then how you follow up with the neurologist is kind of a case-by-case decision, but your wishes, as well as the recommendation from the neurologist. You don't need to see the neurologist very frequently at this point. It can be that you've had that initial check-in. If you have any changes or any concerns, scheduling a follow-up is a lot easier than that new patient appointment. So that's typically how we'll do it.
Great. There's a question about folks who do eventually develop symptoms for SCA6 do often see signs of general clumsiness early in their youth.
This is a really good question. Yeah, I definitely have patients who've described that. And then sometimes people who describe that will say, well, my sibling who doesn't have the gene also says that they, were a little bit more clumsy than their friends growing up. And it becomes very difficult to attribute those changes earlier in life with the disease. I think it's an interesting area for us to learn more. Could it be that there are some changes earlier on that are episodic or intermittent, but most likely it's not related to SCA6.
Here's a problem that unfortunately does happen to ataxia patients quite often. They say my clinical diagnosis for years was SCA6, but when they did a genetic test, they found that they were actually negative. For this individual, could they still have SCA6, or is it likely to be some other diagnosis? And why might there be a misdiagnosis?
Yeah, that's an interesting scenario. I think we need to know a little bit more about what happened. Why was it called SCA6 at the beginning? I will say, I talked a little bit about the CACNA1A gene, and it's a interesting gene for a variety of reasons. There are these three different conditions: spinocerebellar ataxia type 6, episodic ataxia type 2, and familial hemiplegic migraine, that all involve different mutations in the same gene. There are individuals who have mutations in that gene at other locations. And there are scenarios where a mutation at another location within that gene can cause a syndrome that looks like SCA6. So I can't speak to your specific case, but if the genetic testing that was performed was just looking at CAG repeats within that gene, that may not be able to find some other mutations within that gene. But this would be a good thing to discuss with your neurologist. What would be the follow-up kind of plan for testing?
Oh, sorry, I was on mute. there's a couple questions about, is this symptom SCA6 or is this something else? I'm going to throw a couple at you. One of them is extreme fatigue, and another is difficulty with talking, easily out of breath, and struggling with volume.
Great questions. So the first one with fatigue is common in across spinocerebellar ataxias and neurological disease. That being said, fatigue is also often multifactorial. One of the things that any individual with SCA6 that comes into the clinic, we always want to assess how is sleep, and are people sleeping well? Are they sleeping through the night? If sleep is poor, which it is in many individuals with ataxia, that's going to make the fatigue of the disease even worse. So fatigue can be modifiable, even if it's partly attributable to the disease itself. And you'll want to kind of go through and eliminate all the other possible causes of fatigue. Depression is another thing that causes fatigue. And is also modifiable. So while fatigue can be a part of SCA6 itself, there are other components as well.
Mm-hmm. And sorry, what about the respiratory issues that this individual experienced?
It can be. So the speech changes that you get in spinocerebellar ataxia type 6, the coordination of the speech, the regulation of breathing and production of speech, can become dysregulated. And so one of the things that you will do with speech therapy is exactly that, training you to time your breathing, slow down the speech, and help it come out in a more coordinated fashion. But just like with fatigue, other things can cause shortness of breath too. And so it's important to evaluate pulmonary, cardiac etiologies and causes as well.
Mm-hmm. And then one more symptom, headaches. Are headaches a common feature of SCA6?
I mentioned in the CACNA1A gene that familial hemiplegic migraine is one of the conditions that you can get from mutations in other parts of the gene. And you can get headaches with SCA6 as well. I feel like I'm a broken record with saying the same thing about the different symptoms, but at the same time, it's really important to make sure there's not another cause of headaches. Headaches are common, and a variety of different things can cause headaches. So just like with any other symptom, talking with your neurologist, identifying what's the character of the headache, are there any what we would call red flags, sudden onset, nausea, associated nausea, positional component, meaning if you're laying down versus standing up, are there differences in the headache? And by better characterizing the headache, you might gain more confidence. Is this related to SCA6 or is it another process?
Yeah, but I think it's always important to note that even if it is caused by the ataxia, that doesn't mean there's nothing that we can do about it. There's a lot of symptomatic therapies out there for many of the common symptoms of ataxia. Okay. Still have quite a few questions. This is really great. I'm sorry, one more symptom question. Experiencing cognitive issues such as short-term memory and losing their train of thought. Is this commonly associated with SCA6?
There's been a lot of research into the contribution of the cerebellum in cognition. Most individuals with SCA6 don't report overt changes in thinking, memory, but you can get difficulty with multitasking, for example. Short-term memory tends to not be impaired in SCA6. So if I have a patient who comes to me and has changes in memory, I'm often looking to see, is there something else going on? For example, is there concurrent depression that might be impacting memory and concentration? That's a good cause because it's modifiable. Or is there another kind of neurological process as well?
Can you comment a little bit about the current status of gene silencing or gene editing approaches for SCA6?
That's a great question. I might defer that one to the talk later in the month, where Dr. Watt will go into a lot of details about therapeutic approaches. Does that sound good, Lauren? Or
Yep, that sounds great.
okay,
That's happening on April 26th, so I hope everyone tunes in for that as well. There's one question: that can medication for some of these symptom management, can they be prescribed based on symptoms even before you have a DNA confirmation?
absolutely. Yeah, these the medications that I mentioned, they do not require that you have a genetic diagnosis of SCA6. These are medications directed at the symptoms. And I'm just thinking through the list of medications, all of those medications would help with those symptoms regardless of whether you had SCA6 or another ataxia or another condition altogether.
Thanks. For someone who's pre-symptomatic, who is positive for the gene, what would you recommend them they do now to try to mitigate symptoms?
This is a great question, and this is one of the reasons why it's a good idea to, if you test positive and you don't have symptoms, to connect initially with a neurologist. What I tell individuals in this scenario is establish good habits up front. For example, exercise routine, core strengthening, pick up hobbies that will support your health in the long term. Other things like sleep, so if you don't have good sleep habits, trying to establish those good sleep habits early. Those are the main things: staying active, exercise, things that will support core strengthening, and establishing those good habits up front.
Okay. So one individual on the call said that they have SCA42 with a mutation in the CACNA1 gene. Can you comment on kind of the difference between SCA42 and SCA6 in these two genes?
I'm going to have to get back to you on that one. I don't want to say that one off the top of my head without first going through my notes.
Mm-hmm. Yeah, I'll just generally comment that many SCAs are caused by genetic mutations in different channel genes, such as CACNA1A and CACNA1 gene. Sorry, I'm just scrolling through. Sorry, just one moment. There's quite a few folks on the call who had symptoms develop in their late 70s. Is that pretty typical? And what kind of progression do you often see with that late onset of symptoms?
We've definitely seen individuals with onset in their 70s. One of the things, so we talked about the CAG repeat expansions, and there's a relationship between the number of repeats and the age of onset. It's not a perfect relationship. So even within the same family, who all have the same number of repeats, you can have quite a bit of variation in what age of onset. It can be up to 12 years difference between two siblings with the same number of repeats. One of the things that's less strong is a relationship between age of onset and how the symptoms progress over time. So if you have onset in your let's say mid-70s versus your mid-40s, to the best of our knowledge, how it changes over time will be about the same. SCA6 is slow, so month to month you don't see changes. It's really on the order of several years that you see changes.
So we have a question that asks, is genetic screening selection a surefire way to eliminate ataxia in future generations? And I'm going to assume that they're talking about that pre-implantation genetic diagnosis with IVF.
I don't know the exact rates of success using that technology, but it's very, very high. The embryos are actually tested to select embryos that do not have the gene, and those embryos are then implanted, and that's how the technology works. So the rates of success with that are very, very high. But I know technologies like this are never 100%. It's probably 99.8%. But they have fertility clinics have people who specialize in this and can give you a lot more detail.
Yeah. In these cases, it's always really great to talk to a genetic counselor and then also a reproductive specialist to learn a little bit more. So can you comment on how you collaborate with other ataxia researchers? And how often are studies on SCA6 published, and how can those interested become aware of these publications?
Great question. We have an amazing ataxia community, both within the United States and across the world. There are organizations like NAF really help bring together researchers from all over so that we're working together. We're working in concert rather than competing, and we're leveraging the expertise of everyone everywhere. It's really an amazing community, and feel lucky to be part of it. To learn more about research, the NAF website is a great place to start. You can go. They have a list of different research studies. You can see if you're eligible. You have the contact information of the research team to reach out to if you're interested in learning more or want to participate. Was there another part of that question? I think those are the
I think you covered it. I think we can both say confidently that there are publications being published in SCA6 quite frequently. And one great way to hear about those is through a new NAF partnership with SCA Source, which is a blog written by researchers for patients about updates in research. So that's a great place to start. We only have a couple minutes left. There's a couple of questions about any vitamins that you might recommend or other specific physical exercises.
There's a list of vitamins. CoQ10 is one, vitamin E, B complex, and vitamin C. Those are the 4 vitamins that tend to recommend to anybody with ataxia. There are different reasons for each of them, which happy to go into more. But those are the 4 ones to keep in mind. And then Lauren, sorry, what was the other part of the question?
Different exercises.
Different exercises. I always say cardiovascular and core. If I had to think of 2 things that are at the top of the list, those would be the 2: cardiovascular and then core strengthening for balance. But I really do think of physical therapy as long-term maintenance in ataxias. You want to be checking in with a physical therapist 2 to 3 times per year, updating the exercises you're doing and tailoring them to the functions that you want to promote.
All right. And then I think this will probably be our last question. How common in the ataxia community is SCA6?
It varies by country. There's quite a bit of difference in different countries. In the United States, I think SCA6 is on the order of 10% or so of our autosomal dominant spinocerebellar ataxias. Lauren, you might have the number better, but something in that range is the percentage of autosomal dominant ataxias.
Yep, I can say at least from our NAF membership that it's, I think, number 4 or 5 in the most common ataxias on our list, which may be representative of prevalence in the country. All right, well, since we are about 1 minute away, I wanted to thank Dr. Gupta for joining us today. Hope many of you can join us on April 26th for Dr. Alana Watt's discussion on the research updates in SCA6. And then just as a final note, this webinar will be uploaded to the NAF website and our NAF YouTube. It usually takes about a week or less for it to be uploaded, so you can find it there. So thank you again, Dr. Gupta, and I hope everyone has a great week.
Thanks a lot. Thanks, Lauren. Thanks, everyone.